Okay. One of the other types of nebulizers that are utilized is something called a SPAG, small particle aerosol generator. Uses a jet to create the aerosolization of a medication. The primary use for it was a drug called ribavirin or Aerosol, and it was used as a primary treatment for bronchiolitis, an inflammatory process of the bronchioles, secondary to a respiratory syncytial virus, RSV. It has a drying chamber and produces a very, very stable aerosol in very small particle range, which allows for deposition into the bronchioles as opposed to being in the upper airway. This is what it looked like. You can see the medication reservoir there, creating the nebulization, and then there's this drying chamber which allows for a stabilization of the particle size. We're going to just mention it, that it's done for that purpose, and let it go from there. Ribavirin is no longer a primary. I don't know if I have a slide here or not. Ribavirin is no longer used as a primary treatment for that and for bronchiolitis. So it is used for some other purpose, but for right now, and that other purpose happens to be in immunocompromised patients after post-transplant. They sometimes get a viral infection that the drug is used to treat. But unless you're going to work in that specific environment, all I want you to know is there's something called a SPAG, and it was used to deliver ribavirin. End of story. Okay? Okay. Now, what is used in a lot of places is continuous therapy. We're going to use it whenever we want to have a bronchodilator that's going to be administered over a longer period of time. Instead of just delivering a treatment that lasts 10 minutes or 15 minutes in duration, I'm going to do this over 3-4 hours. Okay? Meaning the standard nebulizer is not going to work out very well. You have to have a specific nebulizer that is utilized. And a lot of ERs will have a protocol set up so when an asthmatic comes in whose the first treatment doesn't break the asthmatic problem, the bronchospasm that is present, they're going to go ahead and turn to a continuous nebulizer where you have what are called heart nebulizers, high output extended aerosol respiratory therapy. I got to figure out some way to make some stupid name up, right? But you can see that the volume that they have are a whole lot higher than our normal, 5 milliliters that we might be nebulizing. We're looking at something on the order of, 100, 240 volume that it goes on. What happens to the concentration of the drug as time goes on? Nothing. Stays the same. Concentration doesn't change. Here's a picture of what some of these things look like. Okay, so it maintains a flow for a long period of time. All right, a couple of things that you need to be given to be able to figure out how much medication you need to place into the diluent to be nebulized. Okay, so the physician's order would read something along the line of 10 milligrams per hour of albuterol. Okay, that's a typical dosage that we would end up utilizing. How many milligrams is in a typical treatment? We didn't talk about that yet, did we? What's the 2.5 milligrams? So here we're basically doing four treatments, if you will, over a period of an hour, but we're going to do this continuously. We know that the albuterol is a 0.5% solution, 5 milligrams per ml. And if you forget, you can look at the bottle. It'll tell you that. We're going to go ahead and have the nebulizer itself creates a aerosol at a volume of 30 milliliters per hour, and the therapy, we want these 10 milligrams per hour to be done over an 8-hour period of time. Okay, So I need to figure out how much medication physically I have to draw up, how much diluent I have to draw up to mix them together. So first thing we want to do is calculate the amount of drug that will be delivered, and that's basically the dosage desired, 10 milligrams per hour, times the duration, 8 hours. Okay. Then we calculate how much total volume is going to be placed into the nebulizer, both the diluent and the medication. Then we calculate how much drug in milligrams is required, and then how much diluent is required. So let's go back to our problem here. The amount of drug we need to have being delivered is 10 milligrams per hour times 8 hours. So that would mean 80 milligrams of medication. The total volume I want to have being nebulized is my output of my nebulizer is 30 milliliters per hour. I'm going to multiply that times my 8 hours, or 240 milliliters. Of that 240 milliliters, some of it's diluent, some of it's medication. How much of that is the medication? Well, I got to convert that 80 milligrams into milliliters to know how much milliliters of medication I have to draw up to place into the nebulizer. So 5 milligrams per ml is the concentration. If I set it up as a ratio where I have 80 milligrams in some unknown number of milliliters, do my cross multiplication, I come up with 16 milliliters. So 16 milliliters of medication, 60 milliliters of albuterol have to be drawn up into a syringe and placed into the nebulizer. Then I got to figure out, well, how much of my total volume is going to be then with normal saline. So 240 milliliters is what the total volume was from step 2. I subtract my 16 milliliters and I find that it's 224 milliliters. Okay? Does that make sense? Hell no, Rick. Good news, if you go to my website, there's a couple of practice problems that are there that you can work through solving it, because you might see one of these on a evaluation tool at some point during this 8 weeks or 6 weeks or 5 weeks, whatever, however many we got left here. Peak flow, if you remember, flow is basically volume per unit time, and we can measure either the inspiratory peak flow or the expiratory peak flow. Normal inspiratory flow is somewhere on the order of 30 to 35 liters per minute. Remember that the DPI, we want to be able to generate at least that, if not more, usually about 50 milliliters per minute, or 50 liters per minute to make the device function. We can measure this peak expiratory flow rate in the pulmonary function lab. We can do with our bedside spirometry, or typically what we use, especially for patients in the home, is a handheld peak flow meter. And we know that with obstructive disease, you end up having a flow limitation, so therefore peak flow is going to be dropping off. Asthmatic specifically, we can monitor, because the medications that are administered, those short-acting beta agonists, will end up having an improvement in peak flow after administration of the medication. So we're going to look at the maximum flow rate attained during that maneuver. And we do this by having them take a deep breath in to total lung capacity and blasting out as hard and as fast as they possibly can. And it's recorded either in liters per second, which is typically how a PF lab would report it, or more commonly at the bedside with a handheld meter. It's typically in liters per minute. What we ideally want to establish, and when Jeannie talks about bronchial asthma and the management of them, part of an asthma plan is establishing a personal best. I can predict, based upon age, gender, and height, what your peak flow should be, but the best way to do it is to have the patient establish their own personal best. Over 2 to 3 weeks, they go ahead and at different times of the day, they go ahead when they're stable and find out what their personal best is. That number then is used to derive what we call a traffic light to tell the severity of the airflow obstruction. This is kind of what the patient fills out and what you might be required to produce on a test. If I tell you what the peak flow personal best is, 80 to 100 of that will be considered in the green zone. The green zone means you're doing good. Everything's fine. Keep on doing what you're doing. 50 to 80% is the yellow zone, and that's the area at which you're heading for an attack and you need to seek medical help. Or you, let me rephrase that. If you're in the yellow zone, it probably means we need to add something to your regimen. And red zone is where you truly are having an attack. It's less than 50% of personal best, and that means you need to seek medical attention. Okay, so it kind of gives the patient an ability to control their own asthma, much in the same way that a diabetic, based upon a glucometer, would be able to alter their dosage of insulin. Okay, so green, yellow, red. It's not really I guess it's an upside down traffic light if you want to think of it that way. So if my personal best was 400, when I get less than 320, or excuse me, as long as I'm greater than 320, I'm in the green zone. Between 200 and 320, I'm in the yellow zone. Less than 200, I'm in the red zone. So the patient would know what they would need to do based upon what they're feeling their peak flow. It's a much more objective way of expressing it rather than you got that feeling. And people those of you who may have asthma know what I'm talking about. There's a certain feeling that you have that it ain't a good day. And this is kind of an objective way of expressing that. So 80 to 100, 50 to 80, and less than 50. If you want to be a geek, yes, there is equations that you can utilize. Nah, we're not going to bother with that. So let it go at that. Normally, males are somewhere around 500 to 600. Females are 400 to 500, but you don't really need to know the normal range because, simply put, you're going to go by their personal best. Okay. And same thing with this. When you get flows that are obviously down below 100, we're considering that to be a very bad point in time. Calculating percent improvement, if you remember back, it's post minus pre divided by pre times 100. And you can use either the FEV1 or the peak flow. We've only talked about FEV1 up to this point in time where you need a 12% change in 200 milliliters. Some authors think 15% improvement in peak flow is considered to be a significant improvement. So best is using an FEV1, but again, that requires some more sophisticated equipment. Peak flow meters are something that a patient can carry on their person and measure whenever they desire. And if I gave you a problem like that, that should be commonplace to be able to solve for it. And it's just showing the significance there. 12% and 200. All right. Let me pause here for a moment and open up Module D. Because now we get into some of the good stuff. I believe this is Chapter 5 in Colbert. Come on, you. And we're basically going to be talking about what types of drugs are used to create bronchodilation, and that's accomplished by relaxing the smooth muscle that constricts the, or that when constricted closes off the airway. And we'll talk about the 3 different ways that we can end up accomplishing this, giving them fancy names, and we'll go through each of the drugs that are going to be clinically relevant for us, and blah, 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 blah. Okay. We talked about drug cards previously. So long as you have some mechanism to have as a reference for yourself, if it's a pocket guide, that's fine. If it's not, you'll need to have something available to you so when you're in the clinical realm. If your clinical instructor asks you, what's the appropriate dose for ipratropium bromide, you can spit out the answer. Oh. Okay, how about another a quick little video here? That would be an aerosol, that's right. What I call that one, why men turn up missing. Okay, let's go back and review some stuff on anatomy and physiology of the airway. We know that the conducting airways have three levels. The mucosal level, which has the ciliated cells that propel mucus on the way up. Again, its purpose is cleansing. There's a submucosal level that have some key structures, one of which is the bronchial gland, which is one of the ways, beside the goblet cells, that mucus is produced. There's also some smooth muscle that's in the submucosal level, along with some capillary and elastic tissue. And finally, on the innermost side, there's some connective tissue that supports the airway, called the adventition. Here's kind of some diagram of it. You can see what is going on there. Okay. Cartilage is lost as you go further and further down. When you get to the bronchioles, there are no cartilage, which means that they don't have something to maintain support, and when there's smooth muscle constriction that goes on, those airways collapse. And again, the muscle that is there in the submucosa changes in its physical structure. You can see here, as you go further and further down, the muscle itself turns more to bands than opposed to a solid piece of muscle. And a constriction of that smooth muscle will affect airway size. This is just showing the smooth muscle you can see that are there in the smaller airways. The term bronchoconstriction, it means that we have a decrease in the diameter of the airway. That can be caused by one of three primary mechanisms. The first one, and probably the one we're going to react to the most, is the bronchospasm itself, where that muscle that is in the airway itself spasms, constricts, and you end up having a limitation of airflow. That same process can also be caused by airway edema. So whenever you have the vasculature becoming more permeable, you end up having fluid accumulation inside the tissues. Tissues swell, they're not going to be able to conduct airflow either. And the third reason would be secretions, and that increased secretions block off and can also lead to mucus plugging. And those three things are three of the pathophysiological mechanisms of bronchial asthma. So as we'll look at maintaining them. All of them cause airway resistance to go up. All of them cause an increased work of breathing and dyspnea, and cause the problems. When I was first starting out in the field, this was the primary thing we focused on, getting rid of that bronchospasm. We did everything we possibly could, medication-wise, to be able to accomplish that. We now realize that this is the primary culprit that we need to address, especially in children. the development of airway edema can lead to structural changes to the airway itself. And there's some evidence that poorly treated bronchial asthma at a young age can lead to long-term pulmonary damage. And you end up having problems in the long term. We know about the sympathetic and parasympathetic systems, fight or flight and the homeostasis, rest and digest. And there's a balance between these two systems that exist. So when I'm in a nice point of air flow, and when airflow is maintained perfectly, there's a balance between parasympathetic stimulation and sympathetic stimulation. We know that there's different neurotransmitters that are present. Again, this is all from prior, we've talked about before, with this being a muscarinic, this being a nicotinic, and this being a either an alpha, beta 1 or beta 2 sympathetic. And we've seen this previously also as far as the different effects that would happen if something was sympathomimetic or parasympatholytic. Notice that the effects are exactly the same. So I can accomplish bronchospasm or bronchodilation by either giving a sympathomimetic or by giving a parasympatholytic. Doing that will actually cause bronchodilation to happen, and we'll talk about these two enzymes, cyclic A&P and cyclic GMP in a second. But basically what sympathomimetics do is they create more of this substance, which leads to bronchodilation. Same thing can be accomplished by inhibiting that substance using an anticholinergic, and we'll talk about that. So we can do this bronchodilation, we said, by stimulating those beta 2 receptors. We're going to call these our front door bronchodilators. And they function by creating something called cyclic A&P, adenosine monophosphate. I can also create exactly the same process by blocking the cyclic GMP, and these are done with what we call anticholinergics or antimuscarinics, and these are our backdoor bronchodilators. And finally, there's a third way that this can be done, although it's a very weak way, but as we'll find, this substance is broken down by a substance called xanthines, and we're going to call those side door. So let's take a look at these a little bit more in depth and using as our base what we call catecholamines. I believe this is blown up in the back of your section, and we'll be referring to this quite a lot. And it's really divided into two halves. Everything on this side will promote bronchoconstriction. Everything on this side will promote bronchodilation. Okay? So I can either do something that blocks one of these avenues and prevents this from happening, or I can stimulate on this side and create it. Okay? It's that balance that is there between the two. Okay? It's a pretty busy picture, isn't it? I don't know where I dug this up from, but I actually like it. So let's go ahead and focus on this left-hand side where I have my beta 2 receptor up at the top, and we're going to find that that causes this cyclic 3' 5' A&P to be created. Okay, so the first thing that is involved is when that beta receptor is stimulated, when a medication comes along and it's specific for that beta 2 site, it causes a substance called adenyl cyclase to be created. That is an enzyme that promotes the conversion of A&P into cyclic 3' 5' A&P, and that A&P is the one that goes ahead then and causes bronchodilation. So beta receptor stimulated, adenyl cyclase is released. Adenyl cyclase converts AMP into cyclic AMP, just another form of it. But that cyclic AMP is the thing that specifically causes relaxation of the bronchial smooth muscle and bronchodilation. Question? Patricia. It's this one. This is eventually broken down into this one. So if by using a beta receptor, or stimulating the beta receptor with a drug like, they have Expiratory here, you can tell how old this slide is. Let's substitute albuterol, because that's one we're going to probably utilize more often. So when albuterol is inhaled, it comes in contact with a beta receptor that it's specific to, beta 2. That causes the creation of a substance called adenyl cyclase. Adenyl cyclase causes cyclic AMP to be, AMP to be converted into cyclic AMP. It then causes bronchodilation. Over time, this substance, the cyclic 3' 5' AMP, is broken down into 5' AMP, which is ineffective. But there are drugs that inhibit that breakdown, and these are what we're going to call the side door. Phosphodiesterase inhibitors.
So the beta 2 receptor, that's the first door?
That's where the whole process starts. And these are front door, correct. Yep. You have relaxation of the smooth muscle in the process. That's the ultimate goal you want to end up having. And again, we talked about how that cyclic AMP is broken down into AMP, and anything that we can do to block that breaking down will end up having bronchodilation. Now, this is a simplified method that I would probably focus on because it's not as jumbled up. But I have my beta adrenergic agonist, so say my albuterol. It's on, I think it's on the flip side of that, or next page or something. That stimulates the receptor. The receptor then causes, when it's stimulated, causes adenyl cyclase to be created. This is an enzyme that converts ATP into cyclic AMP, adenotriphosphate into cyclic adenommonophosphate. No, it doesn't. That's the wrong one. Yep. I think you're on the back of the other sheet there, Mike. That then causes an increase in that cyclic AMP, which promotes bronchodilation. When there is a shortage of that substance, it's going to flip in the opposite direction. So that's the process we do to promote bronchodilation, is stimulating the conversion of ATP into cyclic AMP. Got it?
Adenyl cyclase is the same thing as adenyl cyclase?
Yeah, I don't know why they,
Okay.
yeah. Here, get rid of that 8. I've never seen anything other than adenyl cyclase, so. Very important process that you'll need to get down.
You said when there's a shortage, it'll flip upside down.
Well, cyclic AMP is a thing that's, when it's present, bronchodilation happens. If for some reason there's a shortage of that, you're going to have bronchoconstriction happening. Now, yes, Dana.
On the bottom, where it has like the normal tone and then the constriction.
Right.
Why is that there? Like the constriction.
Go back to that scale.
Okay.
I can either have bronchodilation by having an increase in this, or by having a decrease in this, and we haven't got there yet.
Okay.
Okay.
All right.
But if I had an increase in this cyclic GMP, that would promote constriction.
Okay.
It's the other end of the scale.
Okay.
Now, this was, if you're really bored one day, I'm going to go back and look. July 2007 respiratory care, which you guys know what respiratory care is, right? Mary talked about it? No? Ray or Jeannie didn't talk about it? The journal Respiratory Care, right up there on the wall. Okay. That's your journal. That's your profession's original research that is done. Okay. But that whole the thing I just drew, or that you just saw drawn there, this is what it really looks like on a cellular level, where those receptors are actually winding in and out of the cells to the submucosal level. Good to God in heaven. So as that drug stimulates these, you end up having this process going on. This is way too confusing for my blood. You know what I mean? The drug acts with the beta receptor to have the creation of the cyclic A&P, which promotes smooth muscle relaxation. And that's all you need to know about it. Okay? All right. Now, bronchodilators have been around for a long time, and there's lots of natural ones that exist. Moi Huang, I don't know if I'm saying that correctly or not. I don't speak Chinese, although I think sometimes you guys think I'm speaking in Chinese. I'm not sure. But it's been on record as being there from 3000 BC. Early 1900s, epinephrine was used subcutaneously to treat bronchospasm, so we would inject it under the skin. And first used as an aerosol in 1910. You know what a little man is? Probably know him better by this guy. Teddy Roosevelt was a horrendous asthmatic who, for the early part of his life, was basically trapped in his house. And kind of ironic, we think of him now as this naturalist who promoted health and climbing and everything else, but as a kid he suffered from horrendous asthma. But all of these drugs that mimic kind of what epinephrine has done, because remember, epinephrine is an endogenous substance produced by the adrenal glands, right? But all the drugs, the group of bronchodilators that mimic that, we're going to call catecholamines. That's kind of all the group that are similar in structure to epinephrine. So the catecholamines are basically made up of two different groups, or two different portions of it. First one is a benzene ring, and for those of you who may have taken organic chemistry, you're better than I. But it's basically a carbon ring that is present, and it also has then, so I have a benzene ring that has two hydroxyl groups, and I have an amine side chain, which is this portion here, and between the two of them then that gives us the catecholamine. Now an important fact, or two things to keep in mind here. Position of this hydroxyl group, the OH portion, if I move it around in different spots on the chain, I end up changing the duration. How long that medication will last. Changes to the amine side chain, changing the structure of this, will end up having a greater or lesser effect on beta specificity. So what's the ideal? To have a drug that lasts as long as possible and only affects the beta 2 receptors. I don't want it to affect the beta 1 or the alpha effectors. And over time, what manufacturers have done is developed, by changing the position of the OH on the benzene ring, where it's at, longer duration. At the same time, they've also changed structurally this amine side chain to have more beta 2 specificity. And we now have drugs that can be administered once a day and have very minimal cardiac side effects. Beautiful. Okay, let me see if I can get this thing to work. So catecholamine is made up of a benzene ring that has carbons and hydrogens. For our purposes, we're going to just have the hydrogens missing. And you can see the catechol nucleus on the left and the amine side chain on the same. Amine meaning that it has a nitrogen NH2 on it. So catecholamines, because they have similar structure to epinephrine, they mimic the effects of it, and can, as you remember, epinephrine stimulates not only beta 1 and beta 2, but also alpha. So it not only stimulates heart rate, heart force contraction, bronchodilation, but it also alpha meaning vasculature. Okay, and these were the first group of bronchodilators that we're using. Most of them were very fast acting, so they were great for an emergency. But they've developed over time where catecholamines were the base. Now we have other drugs that are called resorcinals, saligenins, and some other ones that we'll talk about as we go along. So our first generation bronchodilator, again, was these group of catecholamines, most specifically being epinephrine. So if I gave you this picture you'd be able to tell me this is I'm kidding. Okay. But epinephrine is the base, and you can see that another drug, isoproterenol, is really similar in structure. Both the OHs in their same spot, but because I've gone ahead and changed this amine chain on the side, it changed some of the effects that it was able to do. It changed a little bit, making it a little bit more beta 1 and beta 2 specific and not as much alpha specific. Okay. These medications are all destroyed by two substances, catecholomethyltransferate and monoamino oxide. Monoamino oxide? Yeah, something like that. Oxide, yeah, there you go. Because these two substances are in the stomach, these drugs could not be given as a pill. It would be destroyed before they ever became absorbed and were able to be utilized. Another downside to them is that tolerance and tachyphylaxis frequently developed. Okay? Good news, rapid onset. Bad news, short duration. The other weirdness to them is that they're inactivated by light and just over time when exposed to air.
Environment sensitive.
Yeah, just if you see them, they'll always be in a brown bottle, so they're not sensitive to the light. And when they become sensitive, they create a substance called the adrenochrome, which you don't need to know, but it was the name of my speedball team when I used to play. So we were the adrenochromes. It's a great name. Okay, tolerance, remember, is the you become tolerant to it. It no longer has the effect that you see for the same dosage over time. Tachyphylaxis is that same process, but happening over a very short administration time. So within the first few doses, you have the effect not working anymore. These are the catecholamines that we typically see utilized. Again, not so much for inhalation, but we will find that this is one of the most common drugs used during a patient in cardiac arrest. We will use a drug called racemic epinephrine, and you've seen this one on your drug sheet. We'll talk more about it. And then there are some other ones that are not specifically for bronchodilation, but are used for blood pressure control. A substance called dopamine and a substance called norepinephrine or Levophed. So let's go back to our first one, epinephrine. This is the generic name. There are a bunch of trade names that are out there. We typically do not use this as an inhalational drug, although I will tell you there is an attempt to resurrect Primatene Mist back. It was pulled off the shelves because it was a CFC inhaler, and they're trying to petition to get an HFA inhaler. To me, this is one of the most dangerous drugs to be sold over the counter. It's pure epinephrine, and you can get some nasty, nasty side effects. We can use this medication as a subcutaneous injection for allergic reactions, bee stings, that kind of a thing. We also use it in our world during bronchoscopy when there's bleeding. It's a potent vasoconstrictor, and it'll stop the bleeding if when they're going in to do a biopsy, say, they yank a piece of tissue out and it becomes a bleeding mess. Okay. We typically do not use it as subcutaneous injection, although in theory it could be. And again, it's a sympathomimimetic. Downside to it is that it stimulates all three receptors. Onset is very rapid, within a few minutes, but the duration is very short. So it doesn't make it as an ideal drug, and you can see some of the side effects. All catecholamines, all pretty much have the same side effects, so as you're memorizing them, it's not tough. I'm never going to ask you to list me 3 side effects of a catecholamine administration, but you should recognize that they all have the cardiovascular effect of palpitations and tachycardia. They all have nausea. And I think all drugs probably have nausea and vomiting as a possible side effect. I don't know about that. I'm exaggerating there. But CNS effects as far as nervousness, shakiness, irritability, and ironically, there also can have paradoxical bronchospasm. So where you think it's supposed to correct it, it actually makes it worse. We're not required to know the dosages, but I will just tell you that it's typically a 1% solution that is utilized. And it's diluted with some normal saline. Primatine mist I have been crossed out, but again, I would not be surprised if that comes back on the market at some point in time. And you don't need to know the subcutaneous, but if you'll notice, it is a different concentration that is utilized. It's 1 to 100 for nebulization, 1 to 1,000 as a subcutaneous injection, and 1 to 10,000 when given during cardiac arrest, either through an IV or intraosseous site. What's intraosseous? The bone. Pardon me? Drill, yeah. These are some of the older catecholamines. Do you guys even have this slide? Yeah. These first 2, old respiratory therapists know Bronchosol was the drug that was the magic drug, because isoproterenol or isoprel used to give people the shakes, so Bronchosol had more beta 2, less beta 1 and alpha, so it had less side effects. Ooh, ah. And then there were some other ones. Interesting one, bitalterol, is a prodrug. Does anybody know what a prodrug is? A prodrug is a drug that in and of itself doesn't do anything, but when it comes in contact with something inside your body, it causes a biological effect to happen. So it triggers something else to actually cause the desired effect to happen. So, racemic epinephrine is one that we do administer, and we know that it comes by a bunch of different names. It's ISOMER or a racemate, meaning that it's got a similar chemical structure but functions in a different way. It's not really a bronchodilator. That's not what we typically use it for. We use it for its alpha effect. And we're going to use it as a decongestant, causing vasoconstriction to reduce upper airway edema, where we would see that with diseases like croup, epiglottitis, and stridor, which might occur post-extubation. Okay? And I know we haven't talked about what croup or epiglottitis is yet, but they're both upper airway inflammatory diseases that we have swelling occurring. Croup is subglottic, epiglottitis is supraglottic, and extubation, when you extubate somebody, pull that tube out, one of the things that can happen is that larynx can actually go into spasm, and you can end up having stridor, and if it's severe enough, asphyxia occurring. So this drug can be utilized to reduce the swelling and reverse the process. Racemic epinephrine. So, going back, benzene ring with a hydroxyl group at positions 3 and 4. These are the catechols, or what is called a catechol nucleus. And they have an amine side chain. We know that they're sympathomimetics. They stimulate alpha, beta 1, beta 2. Changing the structure of or lengthening of the chain causes beta specificity. And changes to the hydroxyl group will end up changing the duration of action. And you should have an idea of how that beta stimulation works with the smooth muscle, that diagram that we went through. Okay, so those were our catecholamines. Those were our primary mechanisms for years and years on how we used inhalationally medication to treat bronchoconstriction. Second generation came along, and these are ones now that have a change in the position. Instead of being at 3 and 4, they're at 3 and 5. Not that that really makes a difference to us in any way. But these are now called resorcinols. And these are a different group of bronchodilators that have a little bit less, well, two things they did. Changing the OH position ended up changing the duration of action. So now instead of only being good for a couple of hours, now we're talking 4 to 6 hours. Second thing that ends up happening, because we changed the position of those OH groups, they also are no longer susceptible to COMT and MAO breakdown. So they can be given as a syrup or as a pill. Benefit from them, I have longer duration than I did with my simple catecholamines. Okay. Two examples that are there, although one of them you probably will see going away within the next year or so, and that is metaproterenol. And terbutaline is an interesting drug for a lot of other reasons that we'll talk about in a sec. So here was my catechol nucleus. What I ended up doing is shifting the position from 3,4 to 3,5. Now it becomes a resorcinol. It's a different structure of that nucleus. And then you can see there's different things attached to the side chains that allowed for longer duration and not having COMT and MAO breakdown. Okay, so that's my resorcinol design. Metaproterenol, I've taken off the list of drugs you need to know because it's basically being phased out because there's better drugs available. Alupent and Metaprel were the only trade names. It actually has been out in the market long enough that it's no longer sold as a trade. It's only as a generic metaproterenol. It had an MDI, but they chose not to change it from a CFC to an HFA, so it just got eliminated. It is currently available as a aerosol solution, a syrup, and a tablet. Slow onset, so you don't get the benefit of having a quick onset, but you got a much longer duration. Okay. And I said probably be removed from the market simply because there's better drugs available. Terbutaline is an interesting one also. It's primarily sold as a generic. Short onset, so that's the good news. You get a reaction very quickly. And it's also a pretty longer acting drug with less side effects than its cousin. Interestingly, there are beta-2 receptors in the uterus. So one of the things that we do is we give terbutaline to inhibit premature contractions. If mom's going into labor before we really want her to go into labor, we can halt that labor. That's called tocolysis by administering terbutaline IV, and it'll actually stop or hopefully stop the contractions and stop the labor from happening. It's not approved for nebulization, although it can be utilized. Again, all FDA approval means is that the medication has gone through testing for use of that. Physicians can order it. It's off-label use, but it can be nebulized also. Other thing that terbutaline, along with epinephrine, can be used is subcutaneously, although we rarely utilize that. There's other mechanisms that are far better without the side effects involved. Third generation. So first generation were catecholamines, second generation were resorcinols, third generation are saligenins. I just love saying that word. Saliginin. And a couple things we did here, we added, instead of just having an OH in that 3-5 or in that 5 position, we now have a different chemical arrangement. And this is called the saliginin nucleus. And again, they are not metabolized by COMT, which means it makes it very long-acting. You can take it as an oral. And they become far more beta-2 specific. And these are the ones that we typically will end up seeing utilized. Our old friend albuterol, terbuterol, which is the one that has the breath-activated inhaler, salmeterol, which is Ceravent, and levalbuterol, which is going to be Xopenex. So here was our change to our nucleus, and again our whole long chain changes also, which allowed for much longer duration of use. Albuterol, as you know, is the most common beta agonist administered, rapid onset, long duration. I'm not sure about 8 hours, but you can get up there. It's available as a solution for inhalation, as an MDI, as a tablet, as a syrup. Also can be used for premature labor, although not as effectively. Can be used for hyperkalemia. One of the things that albuterol has as a side effect is it reduces potassium level. So as we're administering this on a continuous basis, as I was mentioning earlier, where we're using those large volume nebulizers, one of the things we have to pay attention to is monitoring their potassium level, because you can become hypokalemic. Okay. And then Proctalgia fugat is another treatment. It's basically a spasm of the
Sounds like something
anus.
I don't want to do.
Your anal sphincter spasms, and it gives horrendous cramping, and the treatment for it is albuterol inhalation. Go figure. It's one of those weird ones that you'll come across every now and then. Terbuterol or Maxair, again, is a little bit of a modification of the nucleus, but basically the same side chain. Less potent than albuterol, short onset, long acting. Had the BAI, and again, I as far as I know, it's still around, but the plan was to have it discontinued. But until they do, I gotta kind of include it. Salmeterol. Okay, now we're talking about a different breed. Salmeterol is also known as Ceravent, and it has an interesting affinity that it can dissolve into fats. And remember that chain that I had where I showed the beta receptors was actually winding in and out again? What it does is this medication gets into the cell and can actually stimulate the beta receptor, come back a little bit, stimulate it again, come back a little bit, stimulate it again, come back a little bit, stimulate it again. So it basically has a very prolonged length of action. And it does that because it's actually able to instill itself inside the fat and come back and re-stimulate those beta receptors over and over again. 12-hour duration, so we're talking about a BID medication now, as opposed to something which is given every 4 to 6 hours. Very slow onset, so it's not a drug we want to give as a relief medication. We're going to find that bronchodilators are split into 2 groups. Those that are fast-acting that we call rescue medications, those that are very slow-acting but long duration that are maintenance drugs. Okay, so 2 ways to approach this. I can use a fast-acting agent like albuterol if I'm having an attack, or I can prevent attacks from ever occurring by having a maintenance drug, keeping the level at a good point. This is available as a MDI or as a DPI. The Advair is available either as a MDI or Advair discus. Remember, the discus is the one that you turn, you click, and crunches the pill up. And the good news about it is it's a BID dose, but it is a maintenance drug. You would never want to give this drug for an acute attack. Do I need to say that again? You never give this drug for an asthmatic attack. You do it to prevent an asthma attack from ever happening. Okay? Maintenance. This is what it looks like. And so it says longest acting. That's not true. There actually is one that's longer acting now. They're getting better and better at this process. You confused yet? Can I keep going, or are you burnt? Okay, I'm going to keep on going then. Remember we talked about isomers before, or racemates. These are basically chemical compounds, same molecular formula, but they're kind of put together different. Okay? How they're arranged are a little bit different. So even though it's the same chemical, how it's arranged changes a little bit, and they become they have different effects. Example are epinephrine, racemic epinephrine. And we'll find that there's a racemate of albuterol where albuterol has these two isomers, a left one and a right one. The right one is the one that does all the work. The left one actually is one that we think has a lot of the causes of the side effects that occur with it. So what the drug manufacturer, and these are their slides, so yeah, okay, a little bit, I don't want to imply that I have any bias toward this medication, because I certainly don't. But what they said is I'll take away that left hand, the S isomer, and just have my R isomer, because that's the one that's doing the work anyways. And we call this drug levalbuterol, or better known as Xopenex. It is a single isomer, just the R side, which is where the bronchodilation occurs. It's available as a solution for inhalation, also available as a MDI. Short onset, which is what you want. Long duration, which is what you want, and in theory you get TAD dosing. Again, some debate about that claim about less side effects. It's always the push that they had is that if you're having a patient who's developing tachycardia, when you're administering albuterol, levalbuterol would be a better alternative. Some debate about that. And TID dosing, yeah, right. It's still ordered the same way. Even though bronchodilators have gone from a point in time where we would give that drug Bronchosol way back when in 1980, we would give it every 4 hours. Guess how often we give albuterol? Every 4 hours. Even though it has an effect that's a lot longer than that. Old habits die hard, I guess is the answer there. So 2.5 milligrams of albuterol versus 0.63 milligrams of levalbuterol. It's much more potent. My drug. This is the one I like. Formoterol. Formoterol, better known as Foradil or Performist. It's kind of a unique catecholamine. It doesn't really fall into the classification of a saligenin. It's off on its own a little bit. It is a maintenance drug also, although it does have a quick onset, which is kind of interesting. It will have effects within 10 minutes, but it's considered a maintenance drug. Again, because of that, we don't recommend it being used for an acute attack. Supply it as a DPI. It's the aerolyzer. And it kind of gets one that has a capsule. You got to take it out of its blister pack and put into the device. So formoterol is a drug that is utilized in a lot of as a combination drug with inhaled corticosteroid, as we will see. Its cousin, arformoterol, again, is an isomer of formoterol, relatively new onto the market, twice daily administration. And all of these drugs I've been talking about that are maintenance drugs, we're going to call LABAs, long-acting beta agonists. as opposed to a SABA, which is short-acting beta agonist. So your short-acting would be things like perbuterol, levalbuterol, albuterol. Your long-acting beta agonist would be things like arformoterol, formoterol, salmeterol, any of those. Yeah, so why isn't it in your text? That's a good question. It came out in 2007. You think the edition that is published should be on there. It's not. New one I added this year, indacterol, indacadorol. I can't speak today. Better known as our Capta, once daily. Woo, we finally made the big time. Remember, the fewer times a patient has to take a medication, the more likely they are to take it, to not miss doses in the process. Longer duration either than formoterol or salmeterol. Does have a rapid onset of action, so you see some of the effects pretty quickly on, and it's less cardiovascular side effects. I'm trying to find a downside to this in the process. Does require a fast inhalation with this device, this neohaler, to get that 75 micrograms of medication in. And here's what the inhaler looks like, the little blister pack. You just drop the little pill inside that, or a capsule inside that chamber, close it, push the button, crunches it, inhale it, and you're off and running with it.
Could you go back? We don't have that slide.
This one here?
In the Catecholamine, we don't have. We don't have.
Seriously?
No, it's not on there.
It's under experimental.
Oh, yeah, it's under experimental. It's not. Probably need to update that, don't I? And you probably don't have this one either, do you? Okay, don't worry, it's not out yet in the U.S. At least I haven't seen it yet. But it's also being joined up with another antimuscarinic drug, as we'll find. Yeah. And then there's some other ones that I just make mention of so you can ignore, because I'm never going to ask you this. How about a patch? How cool is that? These are still in FDA process of being approved. So one day maybe you'll be able to see AZD 3199, whatever it ends up being named once it's finally named in the process. Bottom line is there's always this desire by a pharmaceutical company to make it longer duration with less side effect. That's their ultimate goal. This is page 100 in your text, has a listing of all the different types of drugs you have, what the dosages are, what the frequency are, whether they're short-acting or long-acting, and what effect they say. That might be something that'd be useful to study from when you're looking at it. Again, we classify them either as a SABA or a LABA. SABA being the rescue drugs, the first-line treatment in an acute asthmatic attack. Long-acting are maintenance ones that are used as prophylactics to prevent asthmatic attacks from happening. And I've actually added on aformoterol to your long-acting ones. I don't know if it's on your list or not. Now we can actually also put indacadorol on that one also. Now, all of these long-acting beta agonists have what is called as a black box warning. Literally, it's a big black box that's on the packaging saying, hey, this is a drug which has some bad effects for people. Studies have shown an increased risk of exacerbations of asthma resulting in hospitalizations and deaths with patients using long-acting beta agonists. Now, my take on this is I think they were using the drug wrong. They were using a long-acting beta agonist as a rescue drug. Oops. Well, it's not going to work in that case. So we never use them alone in asthma. COPD we do, but definitely not with an asthma. They're always accompanied with an inhaled corticosteroid. That's what the ICS stands for. So when we see a drug like Advair has salmeterol, but it also has an inhaled corticosteroid along with it. Continuous neb, we typically use albuterol, though terbutaline can be utilized. We talked about this. We want to monitor them for potassium levels. because you can end up having a drop in their potassium. Side effects we talked about of all these sympathomimetics. Let it go at that. There's some more of them that are there. Some of them do contain sulfites, which can actually trigger an asthmatic attack. Nasty as that is. Urticaria. What is it?
Hives.
Hives. That's exactly correct. Allergic reaction you can end up having to these. Lastly, let me just mention about some of the sympathomatic decongestants. We talked about racemic epinephrine having that alpha effect, which allows us to reduce swelling that might occur with croup and stridor. There's also phenylephrine that we're not giving as an aerosol, but is a vasoconstrictor, better known as neosynephrine. It's pure alpha. You got a runny nose, it'll take care of it. It'll vasoconstrict, as you all sniffed at exactly the same time. Thank you very much. There are also antihistamines that can be used as a decongestant. Most commonly used is Benadryl, obviously, in the process. So we have catecholamines, we have resorcinols, and we have saliginins in really formoterol and aformoterol and dacaterol. They're kind of they're not really saliginins, although structurally they're similar to that process. And I will stop there because I think